Kirsten is not only a public health medicine specialist, but has also a trained primary care doctor. She has worked in primary care, which is a unique combination, and from a very early stage in her career has had an interest in the quality care of diabetes and in the prevention of diabetes. So Kirsten, thanks for being here.
Thanks, Jim. I guess the good thing about these sorts of events is it gives us the luxury to go back to see where we've come from. And so I've really enjoyed looking back at past presentations. And I said to Jim, any of you who had been to my old office saw that it was full of stuff, but there's actually some really good stuff. And I've got my notes from that original meeting on the 20th of July, and it was fantastic to reflect on some of those things that were said on that day. So, we've already seen that. I can't help but think about my son with the EDGAR Centre, because when I was interviewed for the job and offered the job, between being offered the job and signing my contract, I realised I was pregnant. And I rang Jim and I thought I'd better let him know. And I said, I'm pregnant. I don't think he said much, but anyway, he let me sign the contract. And so he is going to be 20 in exactly 2 weeks' time. So it's very easy for me to remember how old the EDGAR Centre is. And so that little long scrawny thing is when he was about 2 months, and this is the Ngāti and Healthy project up in Gisborne, Tairāwhiti, and I'll talk more about that. And then he is now on our left. That was taken earlier in the year. So gone from strength to strength, and I think that's what the EDGAR Centre's done. So I really want to spend some time talking about and reflecting on the Ngāti and Healthy project. That started before the centre actually started. There was an opportunity that was put forth by the HRC to have a strategic project around type 2 diabetes and its prevention in a predominantly Māori community. And there lies a story in that, and I think it's worth reflecting on that because it was more than just putting it together. We withdrew our first application because we felt the HRC was not really getting what it meant to implement a prevention program in a Māori community. So we wrote a paper about how we went about this, and I was reading it, and it's really, I think, a useful paper. It hasn't had high citation rates, but people now go back and read it more often. And I'd just like to take the it's not working. Whoops. The opportunity, the photo there is Helen Pahau, who really was instrumental in setting this project. She comes from Tairāwhiti, and sadly we lost Helen a number of years ago, but her passion was the prevention of diabetes up on the coast. And it was through a combination of having the HRC opportunity, me meeting Helen at a meeting, and I come from Tairāwhiti, and we had a conversation about we need to do something about type 2 diabetes on the coast. And that's really three ingredients that helped that project get underway. So the conclusion of that paper was that community-wide lifestyle interventions have the potential to reduce the rate of type 2 diabetes and other chronic diseases in high-risk communities, but require a high level of commitment from the health sector, so not just from research, but the health sector, and buy-in from the community. And I think we'd all agree that we would still say the same today, and we're missing that. And that we need adequate commitment, leadership, planning, and resources are required. Absolutely essential. So the beginning of this project, this was, I think, a 2-day meeting, and Jim, we only see a little bit of you, and Sheila is at that meeting, and I don't know if you remember, it was a hot February time, but we spent a day talking about how we were going to implement this project, and we didn't have any funding at that point. And thanks to Jim's, I think your Bristol Myers Squibbs grant, we were able to fund the trip. But that was us at the end of the day, very happy. And I'd just like to acknowledge some of the people there, David Tiffany Leach and Sally Abel, with whom I still work. Clearly Jim and Sheila there, Helen Pahau, Terry Ihau and Kirsten Macaulay. So At that time, at the beginning of the century, 2 landmark papers were published, the Finnish Diabetes Prevention Study and the American DPP. And so the question really was, how do we take this clinical trial evidence and along with Kirsten Coppell's work around insulin sensitivity and embed that within the community to prevent type 2 diabetes? So our project really was to develop and evaluate a community intervention to reduce the prevalence of insulin resistance, what we now call pre-diabetes and type 2 diabetes. And we had a very simple plan. We wanted to know, count the number of people at the beginning who had type 2 diabetes in the community, have an intervention for a 2-year period, have a process evaluation, and then do a post-intervention survey. And so we documented the proportion in the community with type 2 diabetes, so the known and the newly diagnosed, which was just over 10%. And through Kirsten's work, we were also able to estimate the prevalence of insulin resistance, which was incredibly high. And one of my favourite slides really is this from that particular project, because I think it nicely illustrates the burden of type 2 diabetes in the community and the wave that's going to come through. So the green is the diabetes and the blue is the insulin resistance. So I think it really illustrates, and I would argue today, where we need to spend much of our effort. And coming back to Helen, she was just absolutely amazing. She knew her community, and I think this just illustrates having someone who knows the community, giving them the opportunity to create the best way of doing some of this work. And Helen rounded up the local East Coast rugby team who were doing fantastically in the competitions at that time. And these are some of the backyard photos. So it didn't cost a lot of money. She got a camera and away she went, got the people on board and attached a whole lot of fantastic messages. Get hooked on water, low-fat milk builds strong bones. And I know, and I think Jim spent some time trying to bring Sanitarium on board with this project. They got free advertising, we got no funding. Same with Molenbeek. Trim the fat, lean meat builds lean machines. Whole grain bread, so yes, that's Molenbeek, but again, we didn't get anything from Molenbeek at that time. And the final one was fruit and veggies, aim for 5+ a day. And there was another one, build the habit of a lifetime. And I remember talking with Helen, she rang me, she said, my posters are disappearing. She said, it's a real nuisance. But she then discovered that the message was getting home because the kids loved the rugby team. So they were taking the posters home and putting them up in their bedroom. And I think that's, again, a great way of knowing that the message was getting home. And this is Helen's dedication. She was living in Gisborne and drove up the coast. And I don't know if any of you have been up the coast, but it's not an easy road. It's even worse now. But these are some of the good mornings that inspired her. And these are some of her colleagues who worked on the project. They were fantastic kaiwhina who were really committed to the project. And the project did win some awards, so they went to Wellington at some point and won a national award. And so, did we make a difference after the 2 years? And I think overall that there was no change in the proportion of people who had normal blood glucose sugar levels. Insulin resistance decreased in the total there. But if we look at those 50 and under among the women and the men, the proportion who reverted back to normal glucose, and these were 2 cross-sectional studies, so we didn't follow individuals, you can see that there is some hope there. There is a glimmer of hope that those developing insulin resistance, those reverting back to normal, was moving in the right direction. And as far as the process evaluation, there were again some very important messages. There was strong community awareness, and that was with Helen and her team in kaiwhina. There was a positive profile. The community was increasing ownership. The team was committed. There was some evidence of lifestyle changes. And there were some fantastic quotes there. The Ngātiness, our unity is Ngāti Porou, promoting health through tikanga. The sort of thing our hauora should run by us, for us, and meets our needs. And it's focused on our people. And I think we would argue again that today this is the sort of thing we're looking for. However, there were challenges. And again, I think these are very pertinent for today, so that's why I think it's useful to go back and look at these early projects and learn from them. The ongoing funding and tussle to get the funding in the first instance, but we never gave up. And I think things would be easier in terms of team communication because, you know, back in those times, 20 years ago only, it was just phone and teleconferences and organising those. They were a bit of a headache, whereas now we just jump onto Zoom and it's very easy. So I think very quickly. So the other part of the strategy is fully implementing the structural strategy, and that takes time, and that was around changing the type of food in the shop, getting the local organisations on board, and this intervention was for 2 years, and that's something we never really got to grips with, and that takes a long time. And so if we're doing research, we need longer than 2 years of research to do that. I just put there at the bottom, changing staff, and it's interesting, again, going back through my archives. At one of our first meetings, we identified a risk of changing staff, and we never went back and visited it. But it's actually absolutely critical and I think really important, particularly in today's world where things are changing all the time. David, Sally, Terry and Helen all left the organisation about the same time, and there was a big void that really was never filled, and I think that's something we've got to be really cognizant about. I've got 2 more slides, I think. So just briefly jumping to the Otago Diabetes Project, which actually predates the beginning of EDOR, and that was a quality improvement project here in Otago, across the whole Otago region, and it really fell apart because of health sector changes. It was a register that was set up with over 5,000 people and went for 10 years. And it had some really important findings over time. And I was talking to someone earlier, we identified very early that if you get type 2 diabetes at a younger age, that really the path is not good. And trying to publish that paper 10, 15 years ago was extraordinarily difficult, whereas now it's something we commonly know. And from that data on the register, we noticed that we were making a difference around lipids and blood pressure through medication, but we weren't succeeding around weight or HbA1c. And from that, we went on to do the lifestyle over and above drugs and diabetes, and we found that if we did lifestyle advice intensive over the top of drugs, that we could make a difference to HbA1c. That was a clinical trial. And one of my key passions and interests is that we need, if we don't take the clinical trial evidence out into practice, what's the point? And so that moved on to the Hawke's Bay-based project called the Pre-Diabetes Intervention Package. And we are currently analysing that data, and that's up in the Hawke's Bay. And so I think one of the things we need to ponder is we're okay at doing basic research to clinical research, but getting clinical research out into the practice is an ongoing challenge. And so some of the things that I have thought about is translation of clinical trial evidence into real-world settings requires sound relationships between health service providers, researchers and communities right from the beginning. And an RCT is not necessarily the most appropriate design to evaluate the translation of clinical trial evidence into real-world settings. And denying high-risk communities clinical trial evidence needs to be carefully considered. And so we need effective structural change as integral to research in real-world settings and requires adequate resourcing. So not just money, but people too. That's me.